Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Jaume Capdevila. I'm medical oncologist at Vall d'Hebron University Hospital and Vall d'Hebron Institute of Oncology in Barcelona, in Spain. Welcome to this program titled Optimizing Outcomes for Thyroid Cancer with NTRK Gene Fusions, Precision Care, Patient Impact. Joining me today are Gary Bloom. He is the Executive Director of THICA, Thyroid Cancer Survivors Association, in Olney, Maryland, in the United States. Also, Umberto Malapelle. He's the Chair of Predictive Molecular Pathology Laboratory at the University of Naples in Italy. And also Lori Berth. She is the Elizabeth and Michael Ruan Chair of Endocrine Oncology at Massachusetts General Hospital and Professor of Medicine at Harvard University Medical School in Boston. So welcome, everyone. So in this activity, we will first watch a short video of a patient with NTRK fusion-positive thyroid cancer. We will then go into more details on testing for biomarkers and targeted treatment options available for patients with NTRK fusion before discussing some patient cases together. And finally, we will give our thoughts on how to address the clinical challenges and treating patients with thyroid cancer with this rare biomarker. So let's take some time now to watch our patient's video.
I met James about 31 years ago. He was on leave from Ireland, obviously he's in the army. We met in a nightclub and, as they say, the rest is history. Yeah, a real loving family man.
I had my first biopsy and then 2 days later another biopsy, unsuccessful. And then I had to wait entire 2-week 10-day period for an MDT me to get another biopsy. That was, emotional, psychological, very worrying, extremely frustrating.
We went to the hospital to see the oncologist on the Monday, and we obviously both went into the consultant's room. He told James and myself that we'd got the results back from the biopsy and that it'd been diagnosed with a very rare type, rarer than rare were his words, of thyroid cancer called NTRK. The particular consultant had never dealt with it at all. He said in over 30 years of being at that hospital, he'd never dealt with that particular fusion, and neither had anybody else at the hospital.
Yeah, the fact of trying to find out about rare cancer was really difficult. I did find it's internet-based. It's also very American. Struggled with all that, the terminology. Yeah, extremely difficult. But to be honest, I researched it till I couldn't do any more, and then just let it go and trust the consultant. The importance of the diagnosis being quick is absolutely crucial. Essential, I can't stress it. One, for treatment, and given 2 days later in my case, I had to have a brain scan. That's how serious it is. And also, for my own sanity, my family, to try to come to terms with it. It needs to happen as soon as possible.
Initially, it was great, you know. James sort of the pain and because he was quite weak in his legs as well, so he got his strength back again. It was a little bit more active. And it definitely made a difference to start with. but he had to have regular blood tests every 2 weeks. But the problem was the medication was then affecting his liver enzyme functions. So although the medication was helping with the thyroid, it was affecting the liver enzymes. So they were rising, so the medication had to be reduced. Then he had to have a break from the medication. Then it was introduced again. So there's been no consistency in terms of the level. It's got to a point now where the tumour has spread to James's sternum, and he's got quite a big mass on his sternum, which is close to his heart. The medication, just from test results, is showing that the oncologist feels it's no longer effective. However, James feels it does help with his breathing. So he is still taking the medication, but a much smaller dose.
I think personally, you need to go on this journey. You need to be honest with your consultant. What do you want from this? It's a two-way street. Don't just one. So I think that's been absolutely honest. It's been really useful.
I just want him here. I don't want him to suffer. Nobody wants, to see him suffer, but I don't want to lose him either. I just feel he's got to try everything that's available to him. But it has to be James' decision as well. He knows inside how he's feeling, and how he's suffering. And it's a strain for all the family, mentally, physically.
Sadly, James passed away from his illness in the weeks after filming. So, Gary, is what James was describing often experienced by patients when it comes to diagnosis and biomarker testing in thyroid cancer?
In my experience, no. I'm focusing on the word often or as a norm. I don't think at this point patients are being tested for biomarkers with regularity. It depends on who's caring for them. In most cases, we're treated by endocrinologists, as you know, and when does that transition happen to an oncologist? And there's also terminology confusion that I think is also a problem for patients. We have biomarker testing, genetic testing, precision care, genomic testing, and on and on. And I think it's right now we're at a point in thyroid cancer where the patients are very confused about what happens next. And I think that's something we have to all work at in terms of creating more clarity for patients.
If you agree, maybe we can discuss a little bit more about how we test in thyroid cancer, because NTRK fusions, as we all know, are really rare, but they could have a real impact. So Laurie, which could be this impact on patients and their outcomes, this NTRK fusion detection?
Well, so I think that this is a really important point here. As you mentioned, this is a rare genomic alteration that drives thyroid cancers. So we don't see NTRK fusion positive thyroid cancer very much at all. However, just because it's rare doesn't mean that we don't want to think about it and test for it. And the reason why is because not only are the NTRK fusion positive thyroid cancers somewhat unique in terms of the histology and probably also the natural history of the cancer, we also now have very effective systemic therapies for NTRK fusion positive thyroid cancer that's advanced. And because these drugs work so well, we don't want to miss a single patient with this diagnosis.
Maybe this second question goes to you, Umberto. How are patients tested for biomarker in thyroid cancer, in particular for these NTRK fusions? Can you give us some explanations about the samples and the characteristics?
Thank you very much. So First of all, we need to have tissue because this type of testing are carried out by using DNA extracted from tissue of the patients. So we need to have representative tissue coming from the lesion because we need to extract nucleic acids from the tumor cell content. Then we need to pay attention to the methodologies that we can using for this type of test. So we can use, in example, real-time PCR, next generation sequencing, but as Lori and also Gary said, is not so conventional that for NTRK fusion you have a reflex testing approach for our patients because you need to have in place and programs that can give you this opportunity. Also because in the first part of the history for diagnostic needs, NTRK is not in the several minimum requirements panel that we have for our patients, but we have, an example, BRAF or other type of alteration. But in this case, to cover NTRK fusion, you need to use specific technologies like as real-time, next-generation sequencing on tissue samples. Then you can use other type of strategies, but the best strategy is to use these technologies on cytological or histological samples coming from our patients.
And talking about from the patient's point of view, and Gary, what do patients want to know when it comes to biomarker testing for their thyroid cancer?
I would say it starts with, what does this test mean to me? What is it going to tell you? What do the results mean to me again? And is this going to change my treatment plan? And to the extent that there is as an example, the NTRK fusion, where there is a potential treatment option, what happens when that treatment stops working? Because we do know that it eventually will stop working.
Maybe it's a time to review a little bit, which is the evidence behind the NTRK inhibitors that we have today in thyroid cancer.
First of all, we have larotrectinib. So there were a couple of phase 1-2 clinical trials that were done internationally in adults and pediatric patients with NTRK fusion driven cancers. So overall, there were 153 evaluable adult and pediatric patients with solid tumors driven by NTRK fusions, and the objective response rate of all of the patients enrolled in these phase 1 and 2 trials was 79%. Now, if we drill down and take a look at the patients just with thyroid cancer that were enrolled in these phase 1 and phase 2 trials, first of all, I think it's important to highlight that thyroid cancer was the most common adult diagnosis enrolled in these phase 1-2 trials. And I think it's important to think about these as two separate groups because they did very differently with larotrectinib. Of the patients with papillary thyroid cancer and poorly differentiated thyroid cancer, the objective response rate was 86%, and the duration of response was very long. As a matter of fact, at the most recent data cutoff, the median progression-free survival in that cohort still had not yet been reached, but at 2 years, the progression-free survival rate in the more well-differentiated thyroid cancers, it was 84%. Whereas in the 7 patients that were enrolled with anaplastic thyroid cancer, unfortunately, the objective response rates and median duration of response was really not nearly as good. The objective response rate for the anaplastic thyroid cancer patients was just 29%, and the median progression-free survival was just 2.2 months. Now, in terms of tolerability, larotrectinib is very good. The grade 3 or higher adverse event rate was just 13%. So overall, patients do tolerate larotrectinib very well. Now, there's also been some real-world data taking a look at larotrectinib in patients with solid tumors driven by NTRK fusions, including patients with thyroid cancer. And this real-world data, which was a matched comparative effectiveness study, what we saw in the patients with thyroid cancer was that the overall survival is much longer with larotrectinib compared to other TKIs that might be used to treat patients with thyroid cancer. The time to next treatment was also much better. Now, the second drug that was approved was entrectinib, and entrectinib is a pan-TRK inhibitor, but it also inhibits ROS1 and ALK. In the pooled analysis of the phase 1-2 trials with entrectinib, there were 13 patients enrolled that were treated with thyroid cancer with a median follow-up of 25.8 months. The objective response rate overall for the pooled analysis, which had 121 patients with solid tumors, had an objective response rate of 61.2%. And then in the patients with thyroid cancer, the objective response rate was 53.8 months. So the objective response rate with entrectinib, while there's not a head-to-head comparison, wasn't quite as high as we saw with larotrectinib. The median duration of response was 13.2 months in the patients with thyroid cancer, and the median PFS was 19.9 months in those patients, with a median overall survival of 19.9 months. In terms of grade 3 or higher treatment-related adverse events with entrectinib across the phase 1-2 trials, there were 41.5% grade 3 or higher treatment-related adverse events, and those included weight gain, anemia, and fatigue. Now, most recently, repotrectinib has been approved by the FDA in 2024 and by the EMA in 2025. The mechanism of action with repotrectinib is basically it was developed to be a next generation in pan-TRK inhibitor, as well as a next generation ROS1 and ALK inhibitor. So it was designed to inhibit the TRK proteins, ROS1 and ALK as well, but also inhibit the acquired resistance solvent front mutations that can arise when patients are treated with TRK inhibitors, ROS1 inhibitors, or ALK inhibitors. So in the trials, the phase 1-2 trials, enrolling patients with TRK fusions that had not received a prior TRK inhibitor, there were 6 patients with thyroid cancer in the 51 patients overall. And in that patient population who had not received a prior TRK inhibitor, in the patients with thyroid cancer, the objective response rate was 100%. Now, in the patients with TRK fusions that had received a prior TRK inhibitor, they had an objective response rate of 48%. The median duration of response was very high in the TRK naive patient population. It had not yet been reached by the time of reporting, whereas in the patients that had previously received a TRK inhibitor, the median duration of response was 9.8 months. The most common adverse events related to repotrectinib included dizziness, dysgeusia, constipation, paresthesias, dyspnea, pleural effusions, pyrexia, muscle weakness, anemia, and pneumonitis were also seen.
So thank you, Lori, for this great update on the NTRK inhibition that we have today. Maybe we can start with the patient's perspective, that at the end is the most important, Gary.
I think first would be that we as a patient organization need to do the best job we can of making our members aware of, again, what these terms mean, and ultimately where does it take them? I mean, what opportunities are there? There's so many more resources available to you as oncologists, which means there's so much more opportunity for us as patients to thrive better, to live better, going back to the video. So we just have to do a better job of getting messaging out to people. And I think one of the things we have to do is get a better appreciation as a patient organization. When do we encourage patients to transition from an endocrinologist to an oncologist? And I know I've spoken to Lori about this. This is a very important question for us because so many of us are treated by endocrinologists.
I don't know how this, because for us, for the clinicians, it's important to translate the data from clinical trials to the daily practice. But the reality in real world is that we are treating many, many, many patients at the end. And we need to collect that. I don't know how if you do that from the pathology point of view, Umberto, because this is not a single mutation. So the interpretation, it's not as easy as a single mutation.
Thank you very much. All the data that Lori showed suggest us that the first thing is that we need to test. And we need to test all the patients also because we need to collect in really structured way this data. For sure, we are talking about a rare alteration, but we need to avoid to have untested alteration, because when you have a rare situation and you have untested alteration, for sure, you have a higher rate of rare situation. So we need to test all the patients to collect this data, and if it's possible to have also a network of people in which we can share this data, because when you are working in one institution and you are testing only the patients coming from one institution, for sure you can have rare situation that you need to manage. But if you are networking with other institutions and you can have other rare situation, you can be in a network of people that can help you to decodify the complexity of this situation.
I think that we can go slightly more on details and discussions, and we may introduce a couple of clinical cases. This is a nice woman that I know for some years. Now she's 69 years old. She's retired, but extremely active, doing completely normal life and completely asymptomatic. That 15 years ago, she started with a surgery not focused on thyroid cancer, goiter, and the patient had a papillary thyroid cancer, an oncocytic variant, so slightly more aggressive than we may expect, 23 millimeters of diameter, and she received a dose of iodine therapy after resection. But well, the disease was there, and the thyroglobulin was slowly increasing, and finally, 7 or 8 years after the initial diagnosis, lung metastases were finally observed, and she received a couple of additional doses of iodine. So here, in this situation, with this long evolution, almost 8 or 9 years of evolution, maybe the first question for you, Lori, could be how we may introduce the molecular testing in this patient.
Well, so I think that testing is needed for this patient now when the lung metastases were observed. So presumably that was several years ago, so she may have been in her early to mid 60s. So I would anticipate that at that point, the patient will live long enough to need other systemic therapies. And so to do the diagnostic, molecular diagnostics at that point, I think is really the important time point to do it.
And Gary, from the patient's perspective, how can we more clear when we explain you the molecular testing?
Statistically, there are some reasons why evaluating the tumor might show a match, but it may not. But it's also, where do we go from here if there is a match? And making the patient understand that, candidly, we're sort of in a transition where we're trying to acquire more knowledge.
I fully agree. This is more or less the topics of discussions that we did together with this patient, because she's a smart woman, and she was pretty clear that the probability to find something was low. But so this is what we did, and you can see in the picture some of the lung metastases that were not huge in volume, but between 1.5 centimeters bilateral lung metastasis, completely asymptomatic. And of course, as you can imagine, she is not willing to take any kind of pills or therapies for her disease because she's completely symptomatic. And we were following the disease, but we did an NGS testing. It's an expensive technique. If you want to do a full NGS testing, it costs, and it's not everywhere easily available. How you may optimize that, or which is your opinion, Umberto?
So, my opinion is that if you're considering in labs that are testing NTRK fusion, for sure, is not only focused on thyroid cancer, but you have a lab that is focused on many types of solid tumors. So you can have in place in your lab an NGS strategies to test all the tumors, because you need to test this type of alteration from lung cancer to salivary glands. So the key weapon is you need to have a concentration of these activities, because you need to make sustainable these activities. Then you need to be exercised, because also for the people that are working in lab, as you have discussed previously, you need to encounter this phenomenon many times, also to be fully aware on how to manage this phenomenon or to transfer this information in a clinical report. So it's not only thyroids. For this is sustainable. But if your focus is only NTRK in thyroids, for sure, NGS is not the best strategy.
Thank you. The images that I showed you before were from March 2023. The images a couple of months ago. Now we can see a slowly progressive disease, but now lesions that are around 2 centimeters. The patient is still asymptomatic, but with some lesions near the bronchus, and that if they grow a little bit more, maybe we may have problems. My discussion with her is, let's say, intense, because probably now, at least in my opinion, we should start therapy. What do you think, Lori?
Oh, that is such a difficult question. When should we initiate therapy in these patients with iodine refractory, progressive, differentiated thyroid cancer when they don't feel sick from their treatment? I think that I love the phrase shared decision making in a situation like this. So I think that is an important thing to take into account. Then, another thing that we really don't know is, will patients do better in the long term in terms of having a longer duration of response, longer progression-free survival, longer overall survival if we start therapy?
I fully agree, and my next point of discussion with this patient was that, with this position of the lung metastasis, if she has symptoms, this will be dyspnea or bleeding, and then it's maybe too late. Now that we have some therapies that are more attractive, let's say, for the alterations and less toxic, this means that we should not justify that starting earlier. So fully agree. But we should not delay too much. Maybe, Lori, you can share your case with us?
Very good. So this is a younger patient. And I think one thing that we haven't discussed is that the oncogenic kinase fusions, NTRK, RET fusions, and rarely we even see ALK fusions in thyroid cancer. Those fusions tend to occur in thyroid cancers in younger patients. So this patient is a 33-year-old teacher who was diagnosed with thyroid cancer in 2019, and she had a total thyroidectomy. She had a papillary thyroid carcinoma that was a diffuse sclerosing variant. It was small, only 1.8 centimeters, but there was extrathyroidal extension, lymphovascular invasion, and focal perineural invasion. There were numerous nodes involved as well in the central compartment as well as in the lateral neck, the largest of which was 4.6 centimeters, and there was extranodal extension present. So maybe I'll just ask Umberto quickly, what do you think of that description of her pathology?
We need to move really fast. So we need to have all the information in your hands and in our hands before to start any decision making. So the type of the histotype and the characteristics of these histotypes with the other characteristics reported, the first thing that are saying us is please go faster.
She received radioactive iodine after she completed her surgery, and there was uptake in the right thyroid bed as well as in the left upper neck. She was followed by an endocrinologist. The TSH was kept suppressed, and she was followed with thyroid ultrasound and thyroglobulin testing every 6 months for 2 years, and then annually was planned. And that's pretty typical for post-op follow-up. However, in December 2023, the suppressed thyroglobulin had increased to 14. The thyroid ultrasound was unremarkable. So the high thyroglobulin prompted a neck and chest CT scan. And you can see on these CTs here that there was a 13.4 millimeter left post-styloid parapharyngeal mass, and then several small lung nodules. The largest one was 12 millimeters, and there was a 12 millimeter enhancing right hilar node as well. So she was being treated at an outside institution at that time, and lenvatinib was initiated at that point in time. She had restaging after 2 cycles and had stable disease. However, by April of 2024, the thyroglobulin had increased to 19, and her restaging CTs showed an increase in the left post-hyaloid parapharyngeal mass up to 19 millimeters. However, there was a decrease in the peribronchial mass as well as a stable 12 millimeter right hilar node. So she had a mixed response to lenvatinib. So we did NGS testing from the original thyroidectomy specimen and found an SQS-TM1 NTRK1 fusion. So maybe I can stop there and ask Umberto, do you recommend always doing a biopsy for NGS testing when patients are progressing on the multi-kinase inhibitors such as lenvatinib?
Thank you very much, Lori. Regarding the NTRK fusion, absolutely is not needed always, because we are talking about a really trunk alteration that coming up in the early phase of the tumor evolution, and we are able to see this type of alteration also on diagnostic material that we have in the archive.
So when we detected the NTRK1 fusion, we did stop the lenvatinib, and then we transitioned the patient to larotrectinib, and that was in June of 2024. I'm curious to know what Gary thinks, what Gary's advice is.
I think that asking that question to me is analogous to when we start our journey and we go for surgery. We hear from the surgeon where there's a risk of laryngeal damage. Potentially, there's a risk of parathyroid complications. There are a number of other complications that can arise in the surgery, and we, as the patient, have the need to engage in a conversation at that point. And now, unfortunately, this patient has progressed and has to have another honest conversation. In my experience, the patient's going to have some measure of these side effects or adverse effects. There's no question, and you can't guarantee that they're going to be mild or extreme for any of us. But you're just trying to make us aware. And I think the next part of it is we have people in the office who you can talk to when you start to feel off.
I love that idea of it being a partnership. So our patient on larotrectinib did develop grade 2 fatigue, but she was able to continue working. She had grade 2 paresthesias involving her arms and legs. She had grade 1 lower extremity edema and grade 1 transaminitis. But nonetheless, these were tolerable for her, and we used supportive care to get her through and be as comfortable as possible. At the initial restaging in August of 2024, she had a decrease in all of the sites of disease. However, her thyroglobulin level didn't drop all that much. It went from 19 to 17. And the patient remains in response now more than 10 months after initiating larotrectinib. She remains on the full dose. She's had no dose modifications. And we do have actually pretty good data that regular exercise does help patients with cancer do better and live longer. And I like talking to patients about that because it reminds me that I want to get good exercise in my life as well.
Fully agree. So thank you for this long and detailed discussion. I don't know if you have some final thoughts.
So from lab side, it's really simple because, as we have discussed, we need to test in really timely, relevant way. We need to be really clear in who to transfer this information in the hands of the labs and the oncologist and the patients. Because when we are able to found these biomarkers, as you have discussed and as Gary discussed before, we are also able to change the perspectives of our patients.
I would say, from my perspective, the most important thing, and I say this to the two oncologists, since you're the ones who are going to speak to us as patients, is hopefully you've started to appreciate who you're speaking to. And the easiest part I heard was get some exercise, which is always important. But in all seriousness, is to make sure that we understand what the options are and what possibilities there are.
Well, so I do think that it is so important to take the time necessary to sit down in a chair with the patient and really go through the broad array of issues that need to be discussed, and make sure that you're taking the patient's perspectives and into account and really getting input from the patient, because that shared decision making really is so key. And then I think we really need to remember to take advantage of the resources that we have out there available to us as clinicians. And our MDTs are a great resource for us to bounce things off of our colleagues and learn from our colleagues.
So fantastic, Lori. And I think that if I should say the final words, and we started from the beginning to say clear messages. No, we said awareness from both parts, from patients and physicians. So Gary, Lori, Umberto, thank you for this. Thank you all of you for participating in this activity. And please continue answering the questions that follow and complete the evaluation, please. And thank you.
This program was presented by Medscape Education Global.